Hi friends, welcome to Rayos125, the online knowledge sharing platform conducted by the Kerala chapter of Indian Society of Radiographers and Technologists ISRT in connection with the 125th anniversary celebration of X-ray invention. I am Prasad PP, Technical Officer, Regional Cancer Center, Trivandrum. In the next few minutes, I am trying to talk about the MR imaging of prostate gland. As the title says, it is not just an imaging technique to detect a lesion, but characterizing a lesion, that is to reach out at a conclusion that whether the lesion is malignant or not. Now coming to the introduction. Prostate cancer is the second most frequently diagnosed cancer in males and the second leading cause of cancer-related death in men after lung cancer. Assessment of prostate cancer can be divided into detection, localization, and staging. Magnetic resonance imaging has been shown to be of particular help in localization and staging of prostate cancer. Now we can have a little about the prostate gland. Prostate gland is a walnut-sized gland situated in the male pelvis. This is the prostate gland. Its position is just in front of rectum and in between urinary bladder and penis. The urethra passes through the prostate gland. The prostate gland has a base, midgland, and apex. Remember, unlike other organs in our body, the base of the gland is in the superior aspect and apex in the inferior aspect. The normal weight of the prostate gland is 15 to 25 gram and the size is 20 to 30 cc. It makes a protein PSA, prostatic specific antigen. The normal value of PSA in blood is up to 5 nanogram per milliliter. Now coming to the indications for doing MR imaging of prostate. Most important one is for the staging purpose of prostate cancer. Second one is in the case of chronic prostatitis to rule out any malignant lesion. Persisting elevated or serial rise in the PSA hormone is another indication. And in the case of suspicious lesion detected in ultrasonography or CT scan. Now, what are the requirements for doing MR imaging of prostate? First one is 1.5 Tesla MRI scanner. Then a phased array body coil is required, which is used for usual abdominal MRI. Then the most important one, the endorectal coil, which is a small radiofrequency coil attached with a long rod and some locking mechanism to fix it in the correct position after introducing per rectally. It is a single-use disposable coil. Then a pressure injector to give contrast medium in a desired volume and flow rate according to the need. Gadolinium-based MRI contrast medium is required, and of course, an expert technologist and a radiologist. Now, coming to the patient preparation. Oral laxatives like Dulcolax tablets are given on the previous 2 days. Soft diet is preferred on the previous day. Better to have a cleansing enema on the day of examination. Nil orally is advised on the day of examination. If not contraindicated, smooth muscle relaxants like injection Buscopan 10 mg is given 20 minutes prior to investigation to minimize the bowel movements. Some contraindications are there for the study. Since we use very high magnetic field, patients with any type of ferromagnetic implants or life supporting devices like pacemakers, stent, etc., are not supposed to enter the magnet room of MRI. Claustrophobia, that is fear of narrow space, is another contraindication. Since contrast injection is needed, patients with altered renal status is contraindicated. Patients with rectal stenosis and immediate post-op or radiotherapy is not ideal for the study as we have to introduce the endorectal coil per rectally. Before entering the magnetic room, strict screening for metallic and electronic devices should be done, failure of which we know may cause a big mishap. Avoid synthetic dress materials which may cause burning of skin because for some MR sequences, the patient's body temperature may increase. The renal status of the patient has to be monitored since we are giving MRI contrast which may cause nephropathy. Informed consent should be taken from the patient and immediate relative. Now, before going to take the usual sequences, we have to introduce the endorectal coil. For that, patient made to lie on the MRI couch over the phased array coil in the lateral decubitus position. Then the endorectal coil can be inserted per rectally after the application of gel for lubrication. This is usually done by a radiologist. The coil is immobilized by injecting 10 to 20 ml of air into the coil and it is locked. Patient made to lie supine and positioned with phased array and endorectal coils. Before going to take the required sequences, we have to check the position of the inserted endorectal coil, which is very important for the success of the investigation. For that, a localizer image is taken in sagittal plane to confirm the position of the coil. The center of the coil should coincide with the center of the prostate gland and it should be as close to the gland to avoid signal loss. Better signal strength will produce better SNR, which is a major controlling factor of image quality. Here we can see the endorectal coil is here and the prostate gland is here. The prostate gland is not in the center of the endorectal coil. This coil has to be inserted little more. Here we can see the prostate gland is here, endorectal coil is here, and the prostate gland is almost in the center of the endorectal coil, and it is very close to the endorectal coil. Then minimal signal loss will be there. Then a higher SNR we can have. Coming to the imaging side, the imaging can be divided into two: the anatomical imaging and the functional imaging. The anatomical imaging is to visualize the anatomy and detect a lesion if any. The functional imaging is not just finding a lesion but to characterize a lesion already detected. Now coming to the anatomical imaging of MRI prostate, there are high resolution T2 weighted images and T1 weighted images. In the case of T2 weighted images, higher resolution T2 weighted images in all three planes, that is axial, coronal and sagittal planes are taken. Slice thickness preferred is 3 mm with an interspacing of 0.3 mm and a FOV of 16 into 16 mm. T2 weighted images provide clear depiction of the anatomy of the prostate gland. Prostate cancer typically displays as an area of ill-defined low signal intensity within a bright peripheral zone. Here we can see the T2 weighted images of prostate gland. This is the high resolution axial images of prostate gland. Here we can see a lesion here. Here we can see a lesion. Here we can see a lesion. Here also we can see a lesion. Now coming to the T1 weighted images. Axial T1 weighted image for the whole pelvis is taken. Slice thickness preferred is 7 mm with an interspacing of 1 mm. It is taken for the evaluation of the contour of the prostate and the status of the neurovascular bundles, which are well seen in the bright periprostatic fat. It is taken as a baseline sequence for calculation of pre-contrast T1 weighting and for the purpose of subtraction. And it is also taken for the evaluation of pelvic nodes. This is the T1 weighted image. Here we can see the prostate gland. The contour of the prostate gland can be seen well in T1 weighted image. Now coming to the functional imaging side, in MR imaging of prostate, we take diffusion weighted imaging, MR spectroscopy, and multi-phase contrast enhanced dynamic study. Now coming to the diffusion weighted imaging. Diffusion is the intracellular movement of water molecules within the tissues. Diffusion weighted image is taken to evaluate the intracellular movement of water molecules. B value is usually set as 500 for prostate. It is taken in all directions. Some post-processing is required for the analysis of the diffusion restriction. Quantitative analysis of diffusion restriction can be done by calculating ADC values, that is apparent diffusion coefficient values. ADC image is helpful to delineate diffusion restriction from T2 shine through effect. Here we can see a bright area in the diffusion weighted image. In the ADC image also it is seen as bright. This is typical for a T2 shine through effect. But in the case of diffusion restriction, here we can see a darker area in the ADC image, which was bright in the diffusion weighted image. The brighter area is converted into a darker area by calculating the ADC value. This is a typical for diffusion restriction. Here also we can see a brighter area which became dark in ADC image. Now coming to spectroscopy. It is a method by which metabolites can be estimated. It adds specificity to lesion characterization. Water and lipid suppressed double spin echo point resolved multivoxel spectroscopy is taken. It is optimized for quantitative detection of choline and citrate. Field of view is selected to get maximum coverage of the gland and to minimize the inclusion of periprostatic fat and rectal air. Outer voxel saturation pulses are required to eliminate signals from adjacent unwanted tissues. Spectroscopy can be of two types, single voxel and multivoxel. This is the planning for a single voxel spectroscopy. It is planned from a voxel from here. We can take only one spectrum at a time, at one acquisition. If we want to take a spectrum from another location, we have to run the sequence again. It was the main drawback of the single voxel spectroscopy. Nowadays, we take multi-voxel spectroscopy usually. In this case, we can cover the entire gland in a single spectroscopy. Single acquisition, we can cover the entire prostate gland. Here we have 1, 2, 3, 4, 5 into 3. 15 voxels are selected at a time. We can have a spectrum from all these voxels in a single acquisition. Some processing is required to visualize the altered tissue metabolism in different locations of the prostate gland. In spectroscopy, we have to look for three important metabolites, that is citrate, creatine, and choline. In spectroscopy, elevated choline peak in comparison with the creatine is an indication of malignancy. Here we can see a spectrum from a normal region. Here no choline peak is there, citrate is elevated. In this case, this is a spectrum from an abnormal area, that is from a cancerous lesion. Here a choline peak is elevated here, and citrate and creatine peak is less. Actually, the ratio choline plus creatine bar citrate is considered. If the ratio is more than 0.886 in peripheral zone and more than 0.94 in central zone, it is significant. Here we can see a spectrum. Here the citrate peak is elevated and the choline plus creatine bar citrate value is 0.393, which is not significant. It is a spectrum from a normal area or from a benign lesion. Here we can see the choline peak is elevated and the citrate peak is inverted actually. The choline plus creatine per citrate value is 1.86, which is very significant for a malignant lesion. Now coming to the multi-phase contrast enhanced dynamic study. High sensitivity in cancer detection. A gadolinium-based contrast is injected using a pressure injector. The dose is usually 0.2 millimole per body weight, and it is given at a flow rate of 2 ml per second. Bolus tracking is done using coronal gradient sequences at the level of aortic bifurcation. A series of T1 weighted gradient echo sequences are taken over a time period of 5 minutes to 6 minutes. Here we can see images at different phases. Here we took 6 phases, 1, 2, 3, 4, 5, and 6. Some post-processing is also required. Graph is interpolated using the contrast multi-phase images with time on x-axis and signal intensity or contrast enhancement on y-axis to know the contrast kinetics or the behavior of the contrast enhancement. By interpolating the graph, we get 3 types of graph. We can see a graph with the time on x-axis and the signal intensity or contrast enhancement on the y-axis. In the first type of curve, we can see the contrast enhancement is or signal intensity is goes on increasing progressively throughout the entire phases. In the second type of graph, we can see in the first or 2 phases, the contrast enhancement is increasing, then a plateau is formed. In the case of the third curve, we can see in the first phase itself a rapid increase in contrast enhancement we can see, then a rapid fall off is there. The type 1 curve, this type of curve, that is the progressive enhancement, is an indication for a benign lesion. The type 2 curve, the rapid or increase in the first 1 or 2 phases and a plateau is formed. This is the type 2 curve. This is an indication of an indeterminate type lesion. We cannot say the lesion is benign or malignant for the time being. For the third type, we can see rapid enhancement and rapid fall off. This is an indication of a malignant lesion. That is, type 1 curve is for benign lesion, type 2 is for indeterminate type lesion, type 3 is for malignant lesion. Here we can see a type 1 curve here. It is from here. This is a benign lesion. This is the type 2 curve. It is from here. This is an indeterminate type lesion. This is a type 3 curve. It is from here. This is a malignant lesion. Now, the coil selection. The coil selection has an important role in the success of the study. For MR spectroscopy, endorectal coil alone is used. For other sequences, the combination of phased array coil and endorectal coil is employed. Now, coming to the sensitivity and specificity. What is sensitivity? Sensitivity is the ability to detect a lesion, and specificity is the ability to characterize a lesion. If we take T2 weighted imaging alone, the sensitivity rate is 88.2% and specificity rate is 67.2%. If we take diffusion weighted imaging alone, the sensitivity is 82.4% and specificity is 81.6%. If we take a MR spectroscopy alone, the sensitivity is 84.3% and the sensitivity is 98%. If we take a dynamic contrast enhanced multi-phase study, sensitivity is 92.6% and specificity is 93.5%. If we take all these 4 sequences, the sensitivity can be increased up to 93.5% and the specificity, that the lesion characterization, can be increased up to 98.5%. Now, coming to PIRADS, few words about PIRADS. It is a structured reporting scheme for evaluating the prostate gland. It is introduced by American College of Radiology. It is nothing but prostate imaging, reporting, and data system. PIRADS has 5 scores, score 1 to 5. For score 1, malignant disease is highly unlikely to be present. For score 2, malignant disease is unlikely to be present. Score 3, malignant disease is equivocal. Score 4, malignant disease is likely to be present. Score 5, malignant disease is highly likely to be present. Now, this is a comparison of 1.1 Tesla with endorectal coil and 3 Tesla without the endorectal coil. At the advent of 3 Tesla and more, the use of endorectal coil has less significance nowadays. The image quality and diagnostic accuracy are more or less same in both the cases. For functional imaging with a bigger FOV, 3 Tesla is better. For morphological imaging with a smaller FOV, endorectal coil has an added advantage. Now coming to the conclusion. MRI allows a one-stop shop for detailed evaluation of prostatic, periprostatic, and pelvic anatomy, especially in the setting of prostate cancer. The availability of functional imaging tools adds to the utility by giving information regarding tissue abnormalities, thereby helping in detection of malignancy. Absence of ionizing radiation is an added benefit. Cost and availability are the only limiting factors. I would like to congratulate the team ISRT and the organizing team of Rayos125 for initiating and conducting such a wonderful, uninterrupted knowledge sharing online platform at a critical situation like this, as the pandemic has disrupted all the physical meetings, conferences, and CMPs. Thank you once again.